Morning, everyone. Good afternoon, good evening, and thank you for joining us here for the second day of the spring meeting. And before handing over to Dr. Truman, I would like to take a moment of your time to explain how we will manage the parallel sessions today. And those of you who have joined us yesterday have witnessed that we were struggling with some unexpected technical issues. And also, on behalf of our platform provider, I would like to apologize for this. And we will consider what we can still do with the presentations from yesterday, because the presenters have not been given the opportunity we intended to share the results, and attendees have not been able to follow all the presentations. And we will get back to you about this. The problem has been identified for most of the issues. However, we have decided that to minimize the chances that we will run into problems again today, that we will switch to Zoom for the parallel sessions, as some of you actually also advised us yesterday. So this is what today will look like. The plenary session will be here on the Plenary platform. When the plenary is finished, you can go to either track A or track B by clicking on the yellow buttons at the bottom of the screen. And we know that some people cannot see these buttons, so we will also place links in the chat. The buttons and the links will appear 5 minutes before the session starts. The link will open Zoom in a different tab. You can leave the Plenary platform open so that you can easily navigate back to it after the parallel session has ended. Once you are in Zoom, there's a Q&A opportunity to ask questions to the presenters, and there's a general chat opportunity for general discussion or remarks. At the end of the parallel session, the host will close the Zoom session and there will be a short break. During the break, you can use the networking opportunities via the Plenary platform. And after the break, you can join again track A and track B from the Plenary platform, again by clicking on the yellow button or using the link in the chat. Again, these will appear about 5 minutes before the session starts. Then again, at the end of the session, the Zoom meeting will close and you will navigate back to the Plenary platform. The final Plenary presentation and closing words take place in the Plenary platform. Then I would like to explain some of the functionalities of the Plenary platform. If you look on the left side of the screen, you will see several icons. The top icon opens the Q&A, and the Q&A can be used to ask questions to the presenter in the plenary sessions. The second one opens the chat, and the chat you can use to type any kind of questions or remarks. Then below that is a one-to-one chat. In the one-to-one chat, you can search for a specific person and invite this person for a one-to-one chat. And in the connections, you can see who is attending the sessions. On the screen now, you also see the yellow buttons that I referred to join track A and track B. And again, these will appear only 5 minutes before the actual session starts. There's also a button for network carousel. And during the first break, after the first sessions in Zoom, if you go back to the Plenary platform, then you can click on this network carousel and you will be matched with a random other person who is also who has also indicated that he wants to join the carousel. And you've got 3 minutes to meet and discuss your research interests. And if you would like to extend, you can click on the extend button and extend the chat for another 3 minutes. So I think that this is it with regard to the explanations. I hope that by switching to Zoom, we will not run into the technical issues again, and that you will be able to listen to the presentations and have some fruitful discussions. Then I would now like to hand over to Dr. Truman.
Thank you, Nika. I will also just take a moment for personal privilege in there. The LRI is made up of a small number of full-time paid staff members and a cadre of seasoned professionals who volunteer their service to the steering committee and on the scientific review committee. We do this because we all recognize the importance and value that can derive from maintaining and promoting a research enterprise in leprosy. Fundamental to that effort is creating forums that promote the exchange of information and inspire collegiality and collaboration. The spring meeting has been the focus of that effort at the LRI, and I think it's a noble undertaking. With the onset of the pandemic, it's been difficult to impossible to conduct business as usual, and we've all been forced to go online. While such utility really benefits our outreach, it adds little to the development of interpersonal relationships, and it comes with the inherent pitfalls that can easily obviate several months' worth of efforts. Yesterday is a good example. I can assure you that all of us, really appreciate and share the frustration that each of you must have from the experience of yesterday. We hope that today will bring a better result and that tomorrow will allow us to return to some degree of normalcy. With that, allow me to introduce our keynote presenter today. LRI University, where he also studied medical microbiology. He is currently employed there and is completing his PhD at the Brighton and Sussex Medical School in the Center for Excellence in Development and Training at Addis Ababa University, which is a World Bank funded venture. The title of his presentation will be Improving Physical and Psychosocial Outcomes Through Integration of Care for Lower Limb Lymphedema and Ethiopia, the Endpoint Study. Dr. Ali.
Thank you very much for giving me this opportunity. Our topic is improving physical and psychosocial outcomes through integration of care for lower limb lymphedema due to 3 neglected tropical diseases, podoconiosis, lymphatic filariasis, and leprosy in Awi Zone, Ethiopia. This is an endpoint project. My presentation outline is first brief introduction, then objective, methodology, result, discussion, and recommendation. These 3 diseases, podoconiosis, lymphatic filariasis, and leprosy, are neglected tropical diseases that cause lymphedema. These diseases mainly affect individuals in low resource settings, and these 3 entities are among priority entities in Ethiopia. Their main outcome of this disease is physical disability due to lymphedema, limb swelling. They also lead to poor social, mental health, and poor psychosocial outcomes. So to address this disease, we conducted systematic review of peer-reviewed journal. We conducted also gray literature review. We did a qualitative study and 3 theory of change workshops. And based on that, we developed an integrated holistic care package. First, this integrated holistic care package was piloted in 1 sub-district. Then it was scaled up into 3 more districts. So the objective of this study is to evaluate the clinical, mental health, and psychosocial outcomes of an integrated holistic care package for low limb disorders due to podoconiosis, lymphatic filariasis, and leprosy. So we assess this by quantitative method, and qualitatively also the objective was to assess the implementation fidelity and assessing the integrated care package, whether it is acceptable, scalable, sustainable, and we also assessed barriers for the integration. What are the barriers for the integration of these services? So the endpoint project has 3 phases. In phase 1, we develop an integrated holistic care package, and we determine strategies for its integration. In phase 2, it was piloted in 1 sub-districts and evaluated. And in phase 3, it is scaled up to 3 more districts, and it is evaluated whether it is scalable or not. And the cost effectiveness was also assessed in phase 3. The study site is in northwestern parts of Ethiopia, Amhara region, Awi Zone, Gwaksa Shukuda district. And the intervention has 4 levels: community level, patient level, healthcare organization level, health facility level. Here I depicted the patient level intervention. In the patient level, one of the modalities of intervention was hygiene. We advise patients twice a daily washing. And we also, all these diseases leads to skin dry skin, so skincare. We apply emollients, and wound is also one of the complaints of these patients. So wound care is part of the component. and also footwear for podoconiosis for primary prevention, for secondary prevention, for others for LF and leprosy as for secondary prevention with footwear, and to improve lymphedema, for proper drainage of lymphedema, we advise also elevation and exercise. And the sixth and the most important component was patient counseling. In previous guidelines in Ethiopia, patient counseling was not addressed well, but in the point, psychosocial intervention and training for health workers on mental health, common mental disorders, and the patients with mental illness can also be managed at the same time. So we have used mixed method modality. This is, for instance, qualitative study focus group among patient group. So we had 4 group of participants, community representatives, decision makers in one group, health professionals in other group, and patients. So the objective is to see whether the integrated care package is acceptable, whether it has a potential for scalability and sustainability, and we also assessed barriers for implementation. Quantitatively also, we assessed the impact of the intervention. We applied intervention. We took at the beginning baseline data, and after collecting baseline data, we applied the integrated holistic care package, and we evaluated as 3 months and 12 months post initiation of intervention. The outcome measures we measured was wound count, whether there is wound or not at baseline in the line, whether there is nodule or not, whether any sign of infection, and limb circumference was also measured at baseline 3 months and 12 months. We used also standardized tools like ODAS2, for instance, WHO Disability Assessment Schedule tool to assess disability at baseline and in the line. Quality of life was measured with dermatology life quality of index, and depression was measured by PHQ-9. Stigma and discrimination. Stigma was measured by internalized stigma scale related to lymphedema, and discrimination was measured by discrimination and stigma scale. We have also assessed the social support, whether there is poor, good, or strong social support using the Oslo social support scale. And whether there is improvement over time was assessed by mixed effect linear regression for outcomes with continuous count, continuous variables. And for categorical or dichotomous variable, we used mixed effect logistic regression. And during this logistic fixed effect was assumed for time point, and random effect for patient or participant variation with person and between person variation was assessed by this model. So key findings, we first conducted cross-sectional study in that baseline. There was misconception about this disease on prevention, treatment. There was misconception. There was high degree of stigma and discrimination. There was also poor quality of life at baseline. The quality of life was poor. We also assessed depression, and there was reduced mental well-being at baseline. There was poor quality of life, reduced mental well-being, misconceptions, stigma and discrimination was very high at baseline. Then we administered the holistic integrated care package, and after intervention, there was significant improvement in clinical outcomes by linear regression. Mean maximum lower limb circumference was reduced by average on -2 by 2 centimeter, reduced by 2 centimeter, and this was statistically significant. Acute attack, this is acute inflammatory reaction. Acute attack also improved significantly, P less than 0.001. Disability as measured by HODAS2 also significantly improved. High HODAS2 is more disability, so the negative value here shows that there is an improvement in disability. There was also significant improvement in psychosocial outcomes, quality of life, also high quality of life. 5-day LQI means poor quality of life, so the negative value shows that there was improvement in quality of life. There was improvement in depression score. Stigma was also improved, and disease-related discrimination, all these values were significantly improved post-intervention. So the key finding from qualitative study, the key finding is integration of these 3 diseases is feasible, and the care package was acceptable. It was acceptable by patients by health professionals and decision makers. Patients, health professionals, and decision makers also assume the care package is scalable and potentially sustainable. Quantitatively, we assess quantitatively and quantitatively there was significant improvement in both physical and psychosocial outcomes. For instance, there was significant improvement in limb swelling, significant improvement in disability, quality of life, depression, stigma, and discrimination. In conclusion, the systematic review tells us disability and poor psychosocial mental health outcomes are associated with PODO, LF, and leprosy. And for optimum management, we conclude that for optimum management of these diseases, holistic care is important. Both physical, MMDP, and psychosocial and mental health intervention is vital. And this research provides a convincing evidence that the endpoint care package is effective across a range of physical and psychosocial outcomes. So the priority actions or recommendation is we need to train primary healthcare workers on MMDP and common mental disorders. In middle and low-income countries, there is a shortage of mental health professionals. So we recommend task shifting to primary health workers. They should be trained on both MMDP and common mental disorders. The other is policymakers should be addressed, high-level awareness raising for policymakers. We have to inform about the cause, the prevention, treatment modality, and proper mobilization should be conducted at high level. And the other intervention is intervention targeting MMDP. Previously, MMDP is a common practice. So with this, we have to integrate the mental care, the social and psychosocial, psychological aspect of care. And this MMDP, psychosocial mental health care should be implemented or delivered at primary health care level because most of the patients have access to PHCs, not higher level, say like hospitals or tertiary hospitals or specialized hospitals. So these services should be integrated at primary health care level. And we recommend also it is scaled up to other endemic districts in Ethiopia and in other endemic countries. Finally, acknowledgement. We acknowledge NIHR for funding this study and other collaborators, Brighton and Sussex Medical School, CDT Africa, Armor Hansa Research Institute, Federal Ministry of Health, Amara Regional Health Bureau, and the study site, Awizon Health Department. Thank you for your attention. If you have any comment or question, you are most welcome.
So thank you very much, Dr. Ali. This presentation will be open for questions. I see there's some sort of note about Krista Kasang, but I see no text underneath it. So while people perhaps are generating questions, in my very naive way, I'll sort of ask that it appears that the elimination of care silos is useful in being able to address all these diseases and eliminate stigma somewhat. So I would guess, or I would ask, is there a challenge then for the education of healthcare workers to be able to do these cross-cutting kinds of treatments? Is there an issue about stigma or prejudice amongst healthcare workers that also have to be overcome to work in these different areas?
Thank you very much for your question. Stigma and discrimination is a very challenging issue. Even stigmatization among healthcare workers was a common practice. And one of the challenges was at first we give common mental disorder theoretical training and 2 days practical attachment. And at first the practical attachment was low, and based on that feedback, we increased the practical attachment to 5 days in mental health hospitals so that the healthcare professionals will get better knowledge. The other is MH gap, the WHO guide for mental health, especially the MH gap. They recommend to be used by primary healthcare workers. We have given them the guidelines for mental health disorders. And the other intervention that we did is mental health professionals routinely mentor the primary healthcare workers. So when they face challenges, when the mental health professionals go there, they will get advice from them. So it is very challenging, but we have tried our best for this holistic care package to be integrated at the primary healthcare level.
Yes, thank you. So the question from Krista Kasang is that in the picture of FGD, there were only men seen. So how do you address the gender issue in this project?
Very important question. This is by chance, actually. This is by chance, but the gender issue should be addressed. Patients, for instance, it is almost 50-50. I think even the majority were patients, majority of patients were females. But in this FGD, as you see, male dominance is there. So we will take the comment as granted.
Okay. Well, we don't see any additional questions here at this point in time. And I'll thank you for your service, for your presentation. Invite others to contact Dr. Ali with questions if they want to, even through the chats or online separately. So with that, then I think that we'll just go ahead and move forward with the remainder of the program. And
thank you very much.
Thank you. And if we're lucky, the next slide you'll see will have little buttons on it that will take you to the next sessions.